appreciate it. Some of the objectives today, and I really try to gear this towards you, and it can be interactive, so definitely feel free to call out, raise your hand, and shout out. I'm going to try to get through what helps you guys and where I can focus on areas that you guys are interested in and want to know more. I've given this talk to a lot of different audiences, so just let me know where you want to go with certain things, areas where you want to know more. But we're going to start with a review of the primary survey. I think all of us kind of find sometimes that we all get a little bit off course, right? You know, we go through all these courses and renewals all the time, but in the real heat of the moment, a lot of times you're drawn to something. Like there's a trauma patient and, oh my God, their foot's hanging off, and you walk over to the foot, right? And that's not necessarily the first thing you should be doing, right? But I mean, I see it all the time in the trauma bay during trauma alerts. I mean, like everyone's hovering around that foot that's hanging on by just skin when the patient's not breathing right, or they're having airway issues and so forth. So I think it's important to maintain the discipline to avoid complacency. Not just in trauma, but in your general practice, as Professor Breon talked about with assessments and so forth. I mean, you got to do it the same way every time so that you don't miss stuff. And I do think when you're doing that, in those occasions where there are bad outcomes, and there's going to be, right, we're going to do everything right and the outcome's still going to be bad, that you can live with yourself. So we'll start with the primary survey. A lot of this is kind of the newer trends in trauma. If you were a paramedic and you stopped practicing 6-8 years ago, a lot has changed, right? Right? How many bags of fluid do you try to get into the patient before you get to the hospital? Right? I mean, for the more experienced paramedics out there, you know, used to get 2 liters in 10 minutes, right? It's changed. A lot has changed. And then if we have time, I have some case scenarios and some ultrasounds too. Does anyone do ultrasound pre-hospital? Dr. Boyer, I knew that. Has anyone talked about it?
So we're adding that to the program starting next year.
Okay.
So we're going to be training all the new medic students starting next year in an EFAS exam.
Okay. Okay, maybe we can help out with that.
Yeah, that'd be great.
It's coming. It's coming. I don't know how long it's going to take. We have it on Life Flight. We just started in the fall, I believe, late summer, early fall. And we're just doing a proof of concept study that paramedics and pre-hospital nurses can do it and get the adequate images and then interpret it correctly. But I think it's only going to expand to things like rush exam to look at the volume and so forth. And I think it'd be great for pre-hospital too. A lot of stuff you can do. Okay, so you guys know the ABCs. You start with airway, and don't forget to take it all the way down to disability and exposure. So let's see. Do you know how I can fix this, Chris? If we can, I can just do it. I do like this though, so I know it's coming up next.
I think it's that, and then
Oh boy, I've never seen this before.
you want the presenter view though, right?
Yeah, if you can, it's no big deal.
Yeah, looks like it won't.
That's okay.
It's not going to.
That's fine.
Do you want the notes or not the notes?
No, I don't need the notes.
Okay.
Chris, is this my phone? It is, if the volume's low.
I don't think it is. We got a couple of tabs.
Oh,
So let's see that. Looks like it's muted, maybe. That's a flash of battery. Finish talking to that.
Okay. Is that better?
College technology.
Okay. So airway, what are you looking at? Okay. Someone's talking to you. That's a great first sign, right? What else?
Sounds.
Yeah. Any facial trauma and so forth. Absolutely. Part of this too, I always try to look at the neck too, assess for any tracheal deviation, any injuries overlying the neck, penetrating trauma and so forth, any expanding hematomas, because those are the signs that you might get into trouble, right? So if you don't have an airway that's patent or you're concerned about one, what are there's 3 definitive indications for airways, right? Call them out. Protect.
GCS less than 8.
Yeah, I take that as
Ventilate oxygenate.
ventilate, oxygenate, absolutely. And for me, oxygenation is the biggest one, right? The brain survives on oxygen and glucose. If you don't have oxygen for about 5 minutes, if you don't have glucose for about 10 minutes, you're going to have an anoxic or hypoglycemic encephalopathy, potentially even die if it's long enough because you get the cerebral edema and so forth. Failure to ventilate, that's a little bit softer. Those would be your COPD patients and so forth. A lot of times these days with just BiPAP, non-invasive ventilation, high flow, we're just not intubating as much as we used to. You know, they have they're real acidotic with a low pH, a high CO2. We can correct that without intubating a lot of times. And we can get repeat gases if we're not correcting, then you do need to intubate. Failure to protect the airway with the GCS less than 8, I think is kind of the weakest one. Just meaning that you have time to do the things that you need to do your full assessment. If I'm in the ER, sometimes we're going right to CAT scan because I want to see what's in the brain, and it takes like 3 minutes, and then intubating them on the way back from CAT scan. If I'm out in the field on Lifeline, someone has a GCS less than 8, and I have a long flight, I'm intubating them on the ground because it's a lot more difficult in the helicopter. Okay, what are some relative indications?
Swelling or, trauma that hasn't completely closed off the airway yet, you suspect.
Yeah. You start seeing like a swollen tongue, bleeding. Sure, absolutely. Those are the big ones. You even mentioned neck hematoma, so that's great. Okay, your definitive airways, obviously you guys know this. It's endotracheal tube, nasotracheal intubation, cricothyroidotomy. Okay, those are the definitive airways. But we have these guys too, the supraglottic airways, and they're often referred to as rescue airways. We're actually, it's in vogue now to try to get away from that, so you guys can be the first to go out and push away from that. Call them supraglottic airways, because when you refer to them as rescue airways, why are you saying that? It's because you failed at getting a definitive airway. Right? And there's nothing wrong, nothing to be ashamed of in putting in a supraglottic airway. And I even find that some of my colleagues, you can watch them struggle with a difficult airway, even getting up to the point of cric, and there's still not a supraglottic airway. And, I've never gotten to this point, but if I did, where we're about to cric, I mean, I'm putting that king in, and I'm ventilating with that while they're doing the cric, or I'm doing the cric. It's nice to be in the trauma bay at a tertiary care center. You get lots of help.
That's kind of the conversation about going away from RSI towards RSA, or sedation or paralytic, towards an airway, not necessarily just an tracheal tube.
Right. Yep. Yeah. Even like the delayed sequence intubations and so forth. There's a lot of talk about optimizing. But what I want to point out here, can you see my mouse? Yeah, good. Give lectures to the residents, I'll be pointing at stuff and they won't tell me they can't see anything. So you can see right here how this big balloon occludes the soft palate to close off the nasopharynx, and then down here up against the base of the tongue to close off the oropharynx, and then the distal balloon goes in the esophagus. So in theory, it should be ventilating the trachea, right? Here's a CAT scan of a guy, this is from the floods of 2011, driving along the road, the bridge was washed out, went off the road, and the front of his windshield struck the opposing bridge abutment right into the car. The Lifeline crew that was on said they couldn't tell which hole was his mouth. So they just shoved a king in one of the holes. And this is the actual CAT scan. on the sagittal view. So it's like cutting me down right straight down through the middle. So you see here's the back of the neck here, front of the neck, okay, spinal column, vertebral bodies. So here, coming in the mouth is the king. Here's the big balloon, including the oropharynx and nasopharynx. Here's the esophageal balloon right here. And where's that port? Right below the epiglottis, ventilating the trachea. Pretty cool, huh? Cricoid pressure. You guys do it, you believe in it? Going to prevent vomit from coming up and getting in your airway?
Previously more frequently.
Yeah, most of the evidence has shown that it's not going to prevent aspiration, vomitus, and so forth. What I would like to refer to any hands on the cricoid is cricoid manipulation. That's to move the airway around to get into view. They found that not only does it not prevent regurgitation, aspiration, if you're putting a lot of pressure on it, it makes intubation more difficult. It should just be more like a gentle sliding around to get that trachea into view. And it's happened to me a bunch of times, like before we started moving away from it years ago, like the trauma surge, I'm trying to intubate and they're just slamming down on the cricoid. And I'm like, let go of it. I can't see anything. And as soon as they let go, the trachea pops into view. Oops. Gave all the answers. So breathing and ventilation assessment. I get happy fingers sometimes. As Professor Brion talked about, get that respiratory rate, get an accurate one. It is estimated a lot. I find in the ER it's always like 18 or 20. I don't know why. But also part of that, a lot of people don't visualize the chest wall, looking for symmetry and so forth, or palpating for crepitus. It might palpate for tenderness, but you know, it takes a little bit of experience. You need to feel that crepitus a couple times. And when you have, you know what it is, right? Snap, crackle, pop. This X-ray here is showing a pneumothorax. So you can see the lungs right up here, and then over here there's another one. You can see the lungs not in this area here. It stops right along this line. Kind of subtle. I will point out, just in case you look at X-rays, I try to go over this with life light a lot. Right here's the carina. So what I tell them is if you see the tip of your endotracheal tube right around the aortic knob here, it's in a good spot even if you can't find the carina. That's about where you want it. That's going to be about 2 centimeters above. Oh, I didn't want to do that. Okay. So chest needle decompression. Usually I can see the next slide that's coming and I prep it. So obviously that's being done in the second intercostal space, mid-clavicular line. Some people are doing it at the 4th or 5th intercostal space along the anterior axillary line also. But the main go-to is mid-clavicular second intercostal space. This is just an X-ray demonstrating chest tubes. Here you can see the chest tube going in. I don't know if they don't have it hooked up to suction or what, but that's still the line of the lung. That's still a big pneumothorax in there. They need to like turn the suction on or something. Generally, if it's just a simple pneumothorax these days, we've moved from doing these big chest tubes that are 36 centimeters to just doing Wayne catheters, which is almost like doing a central line. We just put a needle in, pass a wire, take the catheter off, and then pass the tube over it and aspirate the air. If it's a hemothorax, though, you do need a larger tube, otherwise it clots off. And then, because if it's a hemopneumothorax and it clots off, then you just have to put another tube in because the pneumothorax will recur. The reason why, in this case, this is an anterior one, it goes up here, because when you're laying flat, where does air go? It goes to the top. So you need it anterior. This one's more for a hemothorax, because it goes posteriorly, and blood goes down to the bottom, so you want it lower down. Okay. Circulation, what are you assessing? Okay. I mean, I think when you're doing your airway assessment, that's the first time you're doing a circulation assessment, because they're talking to you, they're perfusing their brain, right? If they're talking to you, but they're confused, they might not be perfusing your brain. So skin color, what else? Peripheral pulse is perfect. If you don't get peripheral pulses, go to central pulses, okay? Cap refill, okay, that's important. Okay, and obviously you're taking a blood pressure, right? And you're throwing them on the monitor and looking at the heart rate. All those are important. Keep in mind the caveat with trauma patients, always check a couple things: antiplatelet drugs, anticoagulation. They have all those new direct oral anticoagulants. The drug companies try to call them novel oral anticoagulants. We call them direct oral anticoagulants, so we don't give them free marketing. You should definitely know that, because you need to tell, we can reverse some of these things. And then beta blockers, calcium channel blockers that block the AV node, they might not mount a tachycardia. I mean, just yesterday, we had a guy that had a huge retroperitoneal hematoma. We eventually found out. He was never tachycardic. His pressure was in the 70s, 60s, 50s. I mean, before we even got to scan, he had 5 units of blood in him and 2 units of FFP. And he was never tachycardic. So, important to note. This is a busy British chart. And what I just really want to point out with this is, you guys don't like jokes, do you? Do you get it? You got it? Okay. Your blood pressure doesn't drop until you've lost 1.5 liters to 2 liters of blood. That's a lot of blood. Keep in mind, a unit of blood's like 400 mLs, okay? So you're losing 2 liters, that's like 5 units of blood or 5 grams of hemoglobin. That's a lot. So you have to pay attention to the early and upfront signs of hemorrhage, the heart rate going up and so forth, because that's the first thing you're going to see. You guys know that. But just to make that point, most people have to lose a lot of blood before they get hypotensive. A lot of times, I think we transiently miss it in the young, healthy person. They have that initial bleeding. They probably will drop their pressure, but then their body compensates by the time you get your cuff on and get their first pressure. And that's why it's so important for us to know if there was any episode of hypotension, because that's a big red flag in trauma. So what do you want to give this person? Okay, you have a trauma victim and they're tachycardic in the 130s and their blood pressures, I don't know, 75 systolic. What are you going to do? You've assessed the patient. There's no signs of external hemorrhage. Pelvis is stable. There's no pneumothorax. Yeah, I think some of you guys are from Delaware, right? Or no? No? Oh, okay. I've been to some of these meetings before, and I know some of the students go to Delaware to rotate. That's still correct, right?
What's that?
Some of the students go to Delaware for...
They do some ride-alongs there, yeah.
They do some ride-alongs there, okay. In Pennsylvania, yeah, we're giving fluids. With critical care transport, they're moving that they can do blood, but that they don't carry it is the problem. In an ideal world, what would you give? Blood, yeah. Okay, you guys only have IV fluids. I think they're adding the option to do plasma light on in the 2019 guidelines, I think. But anyhow, you have your crystalloid. How much are you going to give? You guys pressure 75, his heart rate's 130. Yeah, that's pretty good. I'll get into it. It's on another slide. Okay, here it is. They looked at, this all started, was it 5 years ago that started to make its way into the Pennsylvania protocols, maybe 6 years ago, where in the past, and even ATLS said upfront aggressive fluid resuscitation. They did this big study in 2011, and what they looked at was people who got were allowed to have permissive hypotension with restricted IV fluids versus aggressive IV fluids, the standard 2 liters on the 5-minute ride on the way in. And what they found is that the mortality in the pre-hospital IV fluid group was 4.8%, and in the restricted resuscitation group, it was 4.5%. That doesn't seem like a big difference, right? It's 0.3%, who cares? Let's keep flooding them. But it was almost 1 million patients. So that's significant. So that was the study that led to the changes, where if you have someone that's 75, 85, they have a good radial pulse, they're mentating well, okay, there's no evidence of head trauma, you're going to let that ride. In that same case, if there is evidence of head trauma and they're not mentating well, you want to take it up to 90 and then whoa up. So then in 2015, they did the packed red cells in air medical transport trauma patient study. And what they actually found was that there was increased probability of 24-hour survival, decreased risk of shock, and a lower blood requirement in the hospital in the first 24 hours. So those are really big things. Those are huge. And, kind of based off this, that's when we realized that we need to start carrying blood on life flight. Brady.
Can you just touch on lactate ringers versus normal saline? Because I know we talked about class.
Yeah, there was a study done, I believe it was April 2018. It was in the New England Journal of Medicine. I don't have it on me in my pocket right now, but basically they compared normal saline to balanced crystalloids, is what lactate ringers, plasmolite are called as a group, just balanced crystalloids. And they found that they had less incidence of kidney injury and less ICU time. There's been a lot of studies done that show different areas where balanced crystalloids show some benefit over normal saline. The one that was done in the New England Journal of Medicine last year, obviously that's the New England Journal of Medicine, so it caught a lot of attention. I don't know if that's necessarily the biggest study to hang your hat on and say we need to be doing this, but it's just another study that shows that there's some improved outcomes. My problem with that study is that the average person only got 2 liters of fluids during their hospitalization, which I don't think is a lot. I mean, yeah. So I'm not quite sure what to make out of that. But overall, I would say that, most studies show some benefit over normal saline with balanced crystalloids. The one problem with them is that they're expensive versus normal saline's cheap. But we're probably going to be moving more and more to that. So then now the question is, when do you start the blood transfusion in the trauma patient?
And you're starting blood or packed red cells?
Yeah, packed red cells. When I say blood, I'm interchanging it with packed red cells. Okay. Well, yeah. Here's our protocol. Steve Davis, I think a lot of you probably know him. He did the hard part of this, which is the how to do it. That was the hard part. I got the easy part, which was the when. That was a lot easier. He had that was a lot of logistics and infrastructure building. But our indications there that they can give it off protocol are under A. Okay, so systolic blood pressure less than 90, heart rate greater than 120, or shock index greater than 0.9. Okay. The reason I picked that was it came right out of that study that I just showed you. That's what they were using to transfuse. If they had some other things that they would use to transfuse off a protocol that were listed in B, but I felt that those things were harder to assess in a lot of patients, and it would just make it confusing. So they were just added to, you need to get a medical command order. The one reason we start with a little bit of analgesia and some fluids, if I got into a car accident right now and you measure my heart rate or any of our heart rates, it's probably gonna be above 120. So, giving blood isn't without its risk, but if you're dying, no one should die waiting for cross-match blood. Okay, you just give it. So once you start doing the blood, when do you start giving the FFP and platelets? Oh, it says it up there. Forgot to blow it in. It's around 4 units. Around 4 units of packed red cells, then you start needing to replace the coag factors and the platelets. And then once you do that, you do it in a 1-to-1 fashion. It's one packed red cell, 1 unit of FFP, and it's actually 1/6 of a unit of pheres platelets. They used to do those 6-packs. Some of the more experienced in the room might remember those 6-packs of platelets. It would have been one of those 6-packs, but now all we get is 1 bag of platelets, so it's 1/6 of that.
Could you go back to the previous slide?
Yeah.
I'm going to say a little bit about lactate.
About
lactate.
lactate is a blood test that's basically a sign of decreased end organ perfusion. A lot of things make your lactate go up. For me, it's a red flag in a patient. I find it helpful because it's telling me they're not perfusing somehow, whether it's because they're septic, whether it's because they're hypotensive for another reason. It could be a cardiac arrhythmia, an AFib with RVR that's decompensated, and a trauma patient too. They're losing blood. They're not perfusing the organs. Right, lactate's what's made when you're. What's that?
That's byproduct of anaerobic metabolism.
Byproduct of anaerobic metabolism. Like when you're out sprinting and you start getting that burn and stuff, that's when your muscles are going to anaerobic metabolism and making the lactate.
So, is there going to be relevance of lactate for your hospital?
A lot of aeromedical services do use it as point of care testing. In sepsis, it can be used to guide therapy. You want to see like a drop in the lactate of 25% about every 4 to 6 hours if your resuscitation is appropriate. And even if your resuscitation you feel is appropriate, you're following the guidelines and it's going up, it tells you like something's going on that you didn't find yet. I don't know. I'd have to give that one some thought in just, ground ALS on shorter transports of undifferentiated patients. Let me think about that, if that's all right. So then the next thing that came up, and this is a year ago, right? So this is real hot stuff, the PAMPER trial, pre-hospital aeromedical plasma. What they did is they got 2 groups because now that we're kind of doing blood already. Some services weren't doing blood, so it was a multi-center study. And there were 2 groups, people who got the standard therapy as the protocols were for their aeromedical service. So some it was just that permissive hypotension and crystalloid as needed. For half of them, it was the blood. They'd get the blood up front. And then in the experimental group, whether they would get 2 units of FFP first, and then they would either get the blood or the crystalloid if their parameters were still off. And what they found was a lower 30-day mortality in the plasma group and a lower mean pro time, which is a coagulation test that measures the time to clotting in the plasma group. And when they looked at it, they couldn't, the people that got, they didn't, and when I read through this, I was like, gosh, I wish they'd really comment on the people who got the plasma and the blood, right? Versus the plasma and then the saline as needed. But they didn't ferret that out until last month. So this is really hot stuff, guys. Like you guys are so ahead of the curve now. They looked at that first study we talked about with just the blood. Then they looked at just the plasma study, and they ran numbers and data on that. And what they found was that group that got the red blood cells plus the plasma had the greatest mortality benefit. So now what are we going to do? Carry plasma too? The blood products were kind of made for oncologists that are giving chemotherapy, and they're watching their number. Oh, their hemoglobin's low, let's give them blood. Oh, their platelets are low, let's give them platelets. We're looking at whole blood now because there's evidence out there that whole blood is better because you're getting everything now. We're getting platelets, we're getting plasma, we're getting packed red cells. And in fact, we're starting to give whole blood on traumas starting next month. And as long as everything goes smoothly with that, we're going to move that to Life Flight too. Vasopressors, there's no role for them in the initial resuscitation of a trauma patient. They're hypovolemic, they need their volume replaced. Occasionally you get into trouble where you've like really resuscitated and you just need to buy yourself some time to resuscitate more, maintain brain perfusion and so forth. But otherwise, I mean, that shouldn't be a sole treatment. However, what's the one caveat where you are going to use vasopressors in trauma? Right, spinal shock. Yep. Because actually, those people, they found that if you just keep going hog wild resuscitating them, just blood out the wazoo, plasma, platelets, and just keep doing that, they eventually have a worse outcome. So the anticoagulants, I mentioned that up front, they have those direct oral anticoagulants out there. The main ones we're hearing about right now are apixaban, which is Eliquis, or rivaroxaban, which is Eliquis. No, apixaban's Eliquis. Rivaroxaban, I'm proud of myself because I'm forgetting the brand name. That's appropriate. I should only know the generic names. Xarelto. I don't know why I couldn't think of that. They inhibit factor X, and a neat way to remember that is that there's an X in both of them, and that's how you know what factor it inhibits. Dabigatran inhibits factor 2. That was the first one out. We don't see as much of that anymore, and there's a reason for that. The factor 10 inhibitors, it's been shown that we can reverse it with Kcentra, our prothrombin complex concentrate, but it doesn't reverse dabigatran. So there is a nice, neat, new, expensive drug out there that was created by the makers of dabigatran that reverses dabigatran. It's called dabigabind. So they invented a drug that you can't reverse, and then they invented the reversal agent that's a monoclonal protein that's super expensive. So good for them. But you don't see it as much anymore for that reason. TXA, we use it on LifeFlight. Basically what it does is this little step down here. It inhibits the conversion of plasminogen to plasmin, thereby stopping this step here where fibrin clots are broken down. So the blood already has to clot, and then by doing this, you limit the amount of clot breakdown. There have been several studies that have looked at TXA in trauma. Most of them have been military. In this one, for all comers, look at that top line there. The number needed to treat to save a life is 67. Whenever you hear a number needed to treat, that's how many people you have to give it to have a benefit. And then you just have to look at what that benefit is. For instance, aspirin in acute coronary syndrome is like 24. The number needed to harm with aspirin is like 130, and that's probably like a GI bleed or something, or anaphylaxis, I don't know. So the benefits outweigh the risks. Unlike Tamiflu, where you're more likely to get nausea and vomiting than you are to get one day less of symptoms. And then they did the MATTERS trial. And in that trial, they really looked at the most severely injured group. And in that subgroup, the number needed to treat with TXA to prevent one death fell to 7. So that's pretty darn good. And the stuff's dirt cheap. I'm surprised anyone even makes it. I mean, I'm surprised someone doesn't modify the chemical a little bit and give it a brand name and charge a ton of money. And that's why it's been hard to get data on it. No one wants, because who sponsors all the trials? It's the drug companies, right? Because they want to push out these expensive new drugs that they have on patent. It was hard, and these weren't done in the United States, by the way, for that reason. They were done in Europe and India and even Africa, and then the military, because none of the drug companies would sponsor it because there's no money in it. Okay, so disability. Your assessment, obviously, is the level of consciousness. We go back to, are they talking to you again? So just talking to you assesses kind of airway, circulation, and disability. But then you kind of want to do the full strength assessment and so forth, maybe get a GCS. There it is, the GCS. How do you guys feel about the GCS?
The number's nice, but the description of the parameters is...
Do you know when the GCS scale was invented in, I think, 1974? Do you think it was invented to assess trauma patients? No. No, it was developed by neurosurgeons to assess post-neurosurgical patients in the neuro ICU. It was never intended to be combined. It was never intended to be used to assess trauma patients. It's kind of unreliable. There was a study in the Annals of Emergency Medicine that showed if you get a patient with decreased GCS and you line up EM physicians and have them come along, that, you know, they were throwing numbers all over the place. They didn't agree with each other. And then the next caveat is, since they were never meant to be combined, you can have the same GCS and have a completely different mortality rate. Take a GCS of 4, depending on how that lines up, you have a 50-50 chance or you have a 1 in 5 chance. So I don't know.
I can answer that. There are like 5 things that the billing companies can directly bill from a patient possibly. One of those is the paramedic's interpretation of GCS. There are the non-physician categories. So we keep doing it because the hospital can bill or based upon our GCS.
Well, that makes sense. If you don't understand something, look at where the money goes.
Yeah, right.
So the simplified motor scale is another scale, and it's pretty straightforward. All you're doing is, do they obey commands? That's 2 points. Do they move when you cause noxious stimuli? That's 1 point. And this is where it might get a little bit more difficult between localizing and withdrawing. Sometimes that can be tough for people to tease out. But if they're doing nothing, it's 0 points. And what they found is if the GCS is done right to begin with, the simplified motor scale is comparable with all the things that we use the GCS to kind of predict the need for definitive airway, mortality, and so forth. And then they looked at that inter-rater reliability, and obviously with a more simple scale, more people are going to get the same number given the same patient. It was 83% for the simplified motor scale, where people got the same number versus only 42% agreement with GCS. I stop at noon, right?
Yep.
Okay. Spinal immobilization. This is something that's changed. If you were that medic 8 years ago and you came back to work today and hadn't worked a day since, I mean, you're doing a standing takedown, full board collar, 2 large bore IVs, a leader on each side, right? It's changed. This all started back in the 1960s, and it was over some story where there was like some big football player and he was fine, and then they moved him and he was completely paralyzed. And I think it might have been a kind of more old wives' tale than anything else. But because of that, no one wanted that to happen, right? I don't want to paralyze this patient. And I found back then, you don't see as much anymore, but the person would come in and their saturation would be 70, and there were no airway adjuncts, and the bag valve mask wasn't making a good seal. But I'll tell you what, they were boarded and they were collared, and the best I've ever seen. There was so much focus on immobilization over everything else. Good extrication device. The cons to the long spinal board are a lot. I mean, if it's a long transport, it's a lot of pain, pressure ulcers. It can cause respiratory compromise, especially now. We have a lot of bariatric patients. They never lie flat on their back, or if they do, they go apneic. So there's more cons than there is pros. So there was a study done in 2013, and I don't know how they did it, but they assessed cervical spine motion when someone was being extricated from a vehicle. And they did it with, the person just got out on their own. The person got a collar and got out on their own. They got assisted NSC collar, and then they were just like the full, takedown. And what they found was that self-extrication with a cervical collar resulted in the least movement of the spine. So I think based on this and some other things, that's when they started to think about, do we need to be putting everyone that, bumped into a shopping cart over at Wegmans on a long spine board? And in 2014, the East Trauma Society said that the backboard should really only be used judiciously, which I hate when people say stuff like that, because what's judicious? All the time? So if I'm being judicious, I don't know. Some of the time, very rarely. But we've had the nexus criteria for a long time, and they took that, and that's for the cervical spine. They took that and applied it to the whole spine. And basically, now we finally got into our protocols 4 years ago, I think. If they're mentating well, there's no evidence of intoxication, there's no tenderness, and there's no distracting injury. They don't need to be boarded. Now, what's a distracting injury?
Like foot hanging off, you described earlier.
Okay. Yeah, generally it's a long bone fracture. That's a distracting injury. Their pinky's broken. No. I talked about that. Okay, so we're down to E's, environmental. Even in the summer, someone goes into a natural body of water, they can get hypothermic. So I think it's important to, as part of your good assessment, to remove a lot of the clothing and completely assess the patient. Measure temperature if you suspect hypothermia. Some keys with hypothermia is the temperature of 32. That's when shivering stops and arrhythmias develop. Once you get below 28, which incidentally is 82 Fahrenheit, that's when you develop the arrhythmias that are refractory to ACLS protocol. These patients have very irritable myocardiums, and things as simple as dropping an NG tube or too much movement can precipitate arrhythmias that you're not going to be able to get them out of until they're rewarmed. What do you guys think of this EKG? I'll give you a clue. It's the most common arrhythmia and sign of hypothermia. It's atrial fibrillation with a slow ventricular response. And then you see Osborne waves here. See that? See them up here too. Of course, don't ever let the EKG substitute for getting an actual temperature. Just like if I see peak T waves, I'm not treating them for hyperkalemia, I'm getting a potassium. Okay. One of the keys to know is that passive rewarming doesn't warm you up too fast. And if you're down around that 28 temperature, you really probably need to go to a center that does ECMO or cardiopulmonary bypass, because they can rewarm like almost instantaneously at like a half hour. And that's important, especially if they're in arrhythmia, because you got to get them warm, right? So yeah, indications for active rewarm is basically less than 32. That's, in my experience, has been I've had 2 patients put on cardiopulmonary bypass or ECMO, and they've both been down 27 and 28. So, because if you're right around 32, you can throw on the bear hugger and do all the warm fluids and everything. You get them above 32 pretty quick. But when they're down that low, it's gonna be some time. Okay, I'm just going to run through 5 slides of the FAST. So these are the positions you're doing. You're doing the subxiphoid view to look at the heart for a pericardial effusion, which in trauma would be hemopericardium until proven otherwise. You're looking in Morrison's pouch in the right upper quadrant. That's a potential space between the kidney and the liver. Ditto for that on the left side, except it's the spleen and the kidney. And then you're looking at the bladder to look for any blood around in the pelvis. This is the bladder view. Ultrasound just knows fluid is black. So that's urine in the bladder, but this is blood outside the bladder, and this is blood outside the bladder in the pelvis. This is the right upper quadrant. Normally the kidney right here should be right up against the liver here. And normally there's no space in between them. It's a potential space. If you're bleeding, you're gonna get blood in there because it's posterior. That's where it pools. That's Morrison's pouch. That's black blood in the pouch. This is the spleen here, and this is a more significant bleed. This is a lot of blood, actually. Here's the kidney, and this is all blood. There should be no space in there. The kidney should be right up against the spleen. Another good shot of that. This is the subxiphoid view. Here's the heart. Okay. Here's the blood all around the heart. Okay, that's all I have. Well, maybe I had more. Okay. Thanks a lot, guys. Any questions?
How much are those pre-hospital ultrasounds, or what's the size of them? I mean, what devices?
So the newer ones, there's a probe that basically just plugs into a cell phone or a tablet. They're like $3,000-$4,000 a piece.
Yeah.
So it's become very affordable to do pre-hospital ultrasound.
You can see right on the cell phone.
And they have to connect to a cloud, so when you finish it, you can upload the images. They go anybody at the trauma center, pull them right up and look at what you.
You put it on an iPad, so guys.
GE gave us 2 ultrasound machines. It's probably it's the size of my phone, but just twice as wide. Then the probe, you have wire and a probe. We use Tricify to upload to the cloud, and they hotspot off the pilot's iPad. So it transmits to us. There's only a few of us that have access to it, so it's still in the study phase, but we can see them before they even take off all the images and so forth. It's pretty neat.
Outside using it for diagnostics, like consideration, allowing paramedics to say use it for access purposes.
Yeah, no, we use it in the ER now for access. I mean, we're better than the IV team.
But I mean, extending that possibly to pre-hospital in the future, is that something?
Yeah. Oh, absolutely. I think so. I mean, and I didn't have the slides up there. I need to get them in, but you can look at the chest too. You can see a pneumothorax. So that's a big deal. Then you're not guessing. It's pretty neat. It's eventually going to find its way into ALS. And it has in some areas in the country. It's just nowhere near widespread.
All right. Thank you, Dr. Slimmer.